Hello, and welcome to this episode of In Discussion With from PharmacyUpdateOnline. Today I'm talking to Kalveer Flora about the use of biologics and biosimilars in the management of rheumatoid arthritis. Please can you start by introducing yourself?
So my name's Kalveer Flora. I'm a lead rheumatology specialist pharmacist.
And can you give us a brief overview of your current role, what your job involves?
So my role's quite varied, and I'm very lucky in terms of I get to do quite a lot of different things. So at the moment, I lead the rheumatology specialist pharmacy service at London Northwest University Healthcare Trust. I'm also the lead pharmacist for the rheumatology CRG, which is the clinical reference group for NHS England. And I also support Rheumatology Pharmacists UK, which is a group of specialist pharmacists and pharmacy staff working within the space of rheumatology and biologics. So I've got quite a varied, different role with slightly different aspects to my role. But essentially, it's overseeing the rheumatology services to patients, and that can be a wide range of inflammatory conditions.
Now, last year you co-hosted a workshop on rheumatology at the European Society for Clinical Pharmacy annual symposium. You explained how to optimize treatment with biologics and biosimilars, and you talked about home care. And these are the topics that I'd like to focus on in this interview. But first, could you take a few minutes to tell us how you got started in rheumatology clinics?
So actually, my role developed when the first biosimilar for rheumatology came about back in 2017. And the way the role developed was that actually biosimilars were quite new back then, and we needed a pharmacy or pharmacist champion to really help support the clinical teams in early implementation and adoption of those biosimilars. And so actually that was my foot into rheumatology, and it kind of developed from there. So the rheumatology team had never worked with a specialist pharmacist, and having developed and made the role sort of my own, we identified a niche area, which was the early inflammatory arthritis clinic, that really could use the support of a pharmacist to help increase the turnaround of patients throughout that clinic.
Now I want to focus on biologics in rheumatology. Could you give us a brief introduction to these drugs? What are they and what is their role in the management of rheumatic disease?
So within rheumatology, we use firstly medicines which are called disease-modifying anti-rheumatic drugs. And so we try and use these first for most of our patients. When our patients stop responding to these, or their disease continues, we then add in or escalate their treatments to the biologics or advanced therapies. And these biologics have some of our patients come to us and really say they've transformed their lives, because they actually do what they say. They are fast acting, they control the disease, and actually they get patients into remission very quickly. So we've got quite an array of biologics and advanced treatments that we use in rheumatology. And actually that's often why a lot of other specialties turn to rheumatology, because we've been using these drugs for a long time. And actually they've very, very much so, especially recently, revolutionized the way that we treat patients.
There has been rapid development of biosimilars in the past 5 years. What has their impact been?
So actually biosimilars, again, have widened access to our patients. So 3 or 4 years ago now, NICE, which is the institute that looks at access for patients to medicines, actually decided, because several of our medicines were available as biosimilars, that actually patients with rheumatoid arthritis could access these medicines a bit earlier. So actually patients with moderate disease could be eligible for treatment rather than having to wait until their disease progressed to severe. So actually biosimilars have changed pathways. They've increased access for our patients. And of course, because they are more cost effective than their originators, they've allowed the NHS to really distribute funds and provide more cost effective services.
And could you just clarify what is the difference between a biologic and a biosimilar?
A biological medicine actually is very hard to manufacture. They're not simple medicines such as paracetamol or aspirin that can be manufactured in laboratory quite easily and quickly. Biologics sometimes take a long time, sometimes years to manufacture. And actually, because of the manufacturing process, we can't just call them simple generics, how we do with tablets. So, but clinically, a biosimilar is the same as its originator, and we've got lots of evidence and data to suggest they're clinically equivalent. And actually now, data now suggests that they're interchangeable. So more and more, we should be treating them like generic medicines.
So would it be correct to say that clinically, a biosimilar is to a biologic originator what a generic is to an original drug?
Absolutely, that's correct. So we can't call them the same because the process is so complex in copying and making repeat copies of that medicine. We can't call them the same, which is why we call them similar. However, the therapeutic effect is not similar, it's the same. So it's a bit misleading, the whole biosimilar term.
How does the use of biosimilars play into the sustainability agenda?
So within the NHS, biological medicines, which biosimilars are a part of, are amongst the top 10 biggest drugs that the NHS spends their budget on. And actually, the sustainability thread comes in because a lot of these medicines come as either pre-filled syringes or they're given intravenously. And this causes and uses a lot of plastic. So that's one way it affects the sustainability agenda. However, like we mentioned in the workshop, once we are able to get patients into remission, we are able to potentially extend their doses. And in the longer term, this means that they're using less medicines and essentially less plastic, which has a positive effect on the environment.
I understand that once a patient is stable on a biological disease-modifying anti-rheumatic drug, a DMARD, the dose can be reduced. Could you explain how this works in practice?
Yes, of course. So actually, there's two different parts of that. So guidance actually suggests that we can either lengthen the period, or we can reduce the dose. And so for medicines which are taken as a tablet, so your DMARDs, it's easier for us to reduce the dosage of that rather than extend the interval. However, on the other side, where you've got pre-filled injections, the dosage is fixed. So it's a bit harder for us to reduce that. So what we do as part of clinical practice is extend the dosing intervals. So where a patient may have previously taken a medicine every month, it's then reduced to every second month and so forth. And most of this is as per the licensing of the treatments. Some of it is off label, but that's well established local clinical practice.
I see. And what do patients think about dose reduction?
So actually, where I work, a lot of our clinicians are keen to, once our patients are in remission, follow good clinical practice and either reduce dosages or try and elongate them out as possible. And actually, some of our patients will proactively come to us and say, I've been on this treatment for more than 2 years now. Do I have to continue on this? And so that's when we work to protocols. So sometimes it's patient driven, patients want to take less medicines, patients want to reduce any long-term risks from taking medicines, but actually sometimes it's clinician driven. So if we identify patients who actually have been in remission or stable for a long time, and we do offer them a dose reduction. So it works both ways. And actually, what we found is we've got quite a strong cohort of patients who have managed to do this, and most of them really do feel empowered when taking control of their dosing schedules, and actually they feel listened to because we're able to keep them well and reduce the medication burden as well.
If a patient is in remission, can you just stop the treatment?
So luckily we've got loads of clinical evidence for this, and so for some of our conditions that we see in rheumatology, there's most of our evidence say actually it's better to taper or extend, slowing down, reducing the dose rather than just stopping. So our evidence says that if you just stop, your patient is likely to flare. So what we like to do is slowly taper, because that means that we're reducing that risk of that patient flaring and keeping them well.
Now I'd like to move on to home care. What is the role of home care here, and what are the benefits?
Home care is something that we use to ensure that patients get care essentially delivered to their doorstep. So some of the benefits of that is care closer to home. So for example, patients don't have to attend hospital every couple of weeks to pick up medicines. That also has a sustainability impact. Patients can also be trained in how to use these medicines in their home, and also having home care, which essentially is a third party providing these services, it means that the hospital is freed up for patients who need to be in hospital. So there's loads of benefits of using home care. And actually, when home care services work, they work very well, and they take the pressure of busy secondary care establishments.
And is home care cheaper for the NHS?
So at the moment, medicines that are delivered via home care can sometimes be cheaper, just because some of the way that VAT works.
And does home care involve patients injecting themselves with these medicines?
So home care delivers medication to the patient, and actually, if it's the first time that that patient is having that medicine, a nurse or a trained professional will go to the patient's house, counsel the patient about the medicine, when to take it, how to take it, things to look out for, and actually teach them on how to administer. So that's the first time. There are some treatments that patients, they might feel that they need a second nurse visit, and that's sometimes included via home care. So we use that service, but actually home care is also for the delivery of some tablets, which again means that patients, that don't have to attend hospital to pick up those tablets.
Very interesting. Now I'd like to explore in more detail the role of a rheumatology pharmacist. Could you talk to us a bit about the things that you do?
Yeah, of course. So I guess a lot of my work is overseeing the biologic services from a pharmacy perspective. So it's making sure that the biologics that are prescribed are safe, and actually patients get sufficient access to those medicines. A lot of the biologics that we use require prior approval, which means that the local health economy or the local ICB needs to approve funding for those patients. So a lot of my week is taken up dealing with queries, supporting patients who might come from a different area outside of London. So that's some of the things that we can get involved in terms of a commissioning point of view. I'm also involved heavily in shared care and supporting access to medicines across the interface, so between the hospital and the GPs. I'm also involved heavily with the MDT, so we've got quite a breadth of professionals who work in rheumatology. So it's supporting the nurses, supporting our allied health professionals, our junior doctors, all the way up to our senior consultant colleagues. We have quite a few meetings, so a lot of them are multidisciplinary team meetings, whether that's reviewing patients across the trust or outside of the trust, funding issues. So, if there's patients who need a treatment, but there's a barrier to that. And also it's quite varied in terms of the pharmacy support. So it's it's training and supporting our junior colleagues who are coming through and actually thinking of what to do in the future. So it's very varied, as well as your pharmacist practitioner role. There's quite a lot of facets to the role. So actually each week can be different, but we do have a job plan and various sessions throughout the week. Mostly I'd say my role is probably 80% clinical or sort of patient focused, and the rest is on service improvement, audit, home care review meetings, and so forth.
Most interesting. During the workshop last year, you mentioned some of the positive feedback that you've received from patients. Could you give us one or two examples of the kind of feedback they gave?
So some of the feedback that I guess really stands out and resonates with me is that patients feel that they're actually reducing the pharmacy burden. A lot of patients will potentially have other comorbidities, and for that taking lots of other medicines. And so by getting our patients into remission and reducing it, some patients have said they really enjoy having to inject less frequently, and that really does impact on their life. And also patient feedback is that they're actually very supportive in terms of they didn't know that they could do this, and actually it's so great, we should be offering it to all patients. And so that's some of the feedback that we get.
Good to hear. And now, could you offer us some tips for success in the rheumatology clinic?
I would say for anyone thinking of fulfilling a career within rheumatology or biologics or high cost drugs is actually there's so many opportunities out there to be ambassadors for pharmacy and even supporting the MDTs. So be inquisitive, be intrigued by some of the complex patients and the complex case studies that you see. Ask to attend meetings, be visible, form relationships with the MDT. It's so important to form those professional relationships with your colleagues, and network. Like, I'm a huge fan of networking, because actually your network is your net worth as such.
And finally, for those who have been inspired by your example, what would you say to a young pharmacist who was wondering whether rheumatology is a field that they should specialise in?
I'd say what my boss said to me probably 10 years ago: just try it. And if the shoe doesn't fit, we'll change it. There's no harm in trying. If you don't like it, we can try something else. But I can guarantee you'll probably love it. And that's probably why I've stayed this long, because it's just so varied. There's so many different things that you can learn about. There's so many different conditions. And actually, there's always things changing. So just give it a try.
Kalveer Flora, thank you very much for talking to us about this very interesting and important topic. For more information about Kalveer Flora's work, please visit the website using the links in the description. And be sure to subscribe for more news, videos, journals, and podcasts. For updates straight to your inbox, please follow the links below. And thanks for watching.